Hi there. I'm going to go live now with Dr. Michael Werner, who is the medical director at Maze. And he tends to do the men and I tend to do the women, but he is the medical director of both of them. So hopefully we'll get all of the kinks worked out with it. We're going to be talking about testosterone. And maybe more than anything else, and a lot of you have heard me talk about testosterone, I feel really passionately about our understanding of hormones. And I think that people have a lot of misconceptions when it comes to testosterone. I think that people think of it as just a man's hormone and only men use it, and people think of it as dangerous, and people think of it as something that you have to be really overly cautious about, and you should not consider it unless you have a serious problem. But honestly, I think that is not true, and that we don't really make enough use of testosterone. Even for men, I feel like for men, it's not really okay. So Dr. Werner's now on here, and he is requesting to be on view, go live. Hey, hopefully he's here and we can start this conversation because we both have a lot to talk about. So let's see, it says connecting. He's there.
I'm
It's a
here.
miracle. It's a miracle. People hear about you all the time from me, but then they don't see you. So he really does exist. It's kind of like the Wizard of Oz. Now he's got to get his camera set up so he's not bumping up and down.
Oh, you're so critical.
I am.
Okay.
We're so happy you're here. What's wrong with your camera?
There we go.
He has a lot of really tech, I have to say, he has a lot of really tech savvy sons. Oh my God.
I'm blaming Diane. Okay, we're done.
Okay, blame your wife. Okay, great. Okay, you're there? All is good?
Yep.
Okay, please tell me Diane's not sitting here holding it, because that would be terrible.
No, we put it in the paperclip bin.
Oh, paperclip bin. That's great. Okay. You can see we're super high tech in this place. Okay. Anyway, we're here to talk about testosterone, and I know people are really curious about testosterone, and that people have a lot of misconceptions about testosterone. So maybe you could just start talking about how long ago you started treating with testosterone.
So testosterone actually, people have been treated with testosterone since like the 20s, when they used to grind up pig testicles and inject them into men, but that never really worked very well. So, but we have been using testosterone. Certainly I've been using testosterone since I started the practice, which was 26 years ago. But it's been in pretty common use, I would say, for the last 40 or 50 years. There's been sort of a resurgence of use of testosterone as some of the myths of the dangers of testosterone sort of have lifted. So there was a common misconception that it caused prostate cancer. Yep.
Stop. We'll go into misconceptions, but that's okay. Too much for me. If that's okay, I'm sorry.
Yeah, no.
Okay. So, and just classically, what were the reasons you originally started treating for testosterone? I guess also has that changed over the years, because I'm then going to compare it for what you use it with the men against what we use it for the women. So let's talk about that.
So the main symptoms that men have who have low testosterone that are treated pretty successfully with the testosterone are decreased energy, decreased libido, difficulty taking off fat and putting on muscle, and it has a modest, positive effect on erections and ejaculation.
And do you feel like it's changed over the years in terms of what you've used? Like, did you think about this differently 20 years ago, or is it pretty much the same?
It hasn't really, the indications haven't really changed. It's just that we're much more comfortable using it. There's easier ways and safer ways of using it that have developed. And so that sort of led to the resurgence of using it.
So it's kind of interesting because we started using it for women, I'm thinking about 15, maybe 20 years ago. I mean, not that much longer than that. Because when we started using, I don't know if you remember, DHEA for women, because they hadn't been using so much testosterone for women. And then they started using testosterone for women, and some of the studies started coming out, and you felt really comfortable with it because you felt like it was so safe.
Right. And again, when we treat the women, we're treating them at much lower dosages, more to mimic, what we're trying to do for people is certainly get them to what the normal levels would be for their age group. So that's sort of easy. They've been on that level, and they feel much more comfortable when they have a reasonable level. So it doesn't take, it's not much of a leap to say, it's safe to have levels that are normal.
But you know what's fascinating is that I think there's a lot more data on what's normal for men. I think coming up with one of the problems they've had with women is we don't really know what the normal levels, we don't know what 27-year-olds testosterone levels are, right? Like we're all sort of guessing because they don't do that. But they sort of know it with men. So why do they know with men?
So we know it much less with women than with men, but we don't actually have great numbers for men.
Is that true, really?
Yeah, no, certainly age related. And also different people are different in terms of what numbers they started with. Let's say you start at 600 when you're 30, and then you go down to 400 and you're not feeling well, then that's because you're used to a higher level. So we don't have the longitudinal data on different men. And we definitely feel, just like with the women, that your absolute number is only one piece of the puzzle.
Right. So that gets us to our next thing, which is how do we determine whether somebody's appropriate to have to get treated with testosterone? So why don't you start with the men and then I'll talk about the women, although it's sort of similar.
Right. So there's two pieces. One, the most important piece is they have to have symptoms. So if they walk into my office, let's say they're coming in for an infertility evaluation or something else, and we notice that they have a low testosterone, but they have literally no symptoms of a low testosterone, then we don't have to treat them. We will check them to make sure that they don't have osteoporosis or osteopenia, because that's related to a low testosterone. But if they don't and they have no
They're
symptoms,
related for the men also?
yeah, absolutely.
Really?
Yeah. Yeah.
Because you never hear about those things for men. Fascinating. Okay. See,
Yeah.
the things I learn when I'm doing these. Yeah, go ahead.
Yeah, which is why we check all the men with a sort of a finger bone density when they come in, if they have low testosterone. So if they don't have symptoms, it's nice to know, and then we sort of give them sort of a warning, like, don't be surprised if earlier rather than later you end up with these symptoms, but we don't have to treat you right now. So they have to have symptoms, and then we check their levels to see where they are. And again, it's a complicated issue as to what lab you use and then what actual indice you use, because you can have a high level of testosterone floating around in your bloodstream, but if it gets stuck onto a bunch of proteins that don't let it go out of your bloodstream and into your cells, then it's not doing you any good. So it has to be measured in a fairly sophisticated way.
Right. So I think this is worth us going into a little bit more, because I often have this with the women where they come in and like they say, I've had my testosterone tested in a regular doctor's office and they said I'm fine. And with women in particular, that's an issue, because pretty much unless your testosterone is non-existent and you're dead, they think you're dead. Like they're just going to think you're fine because the levels for women are so non-developed, right? Like basically if you have any testosterone, they're going to say you're fine. And then so and then so then I have to explain to them, like, well, just because they said your testosterone was fine doesn't mean it was a decent level. But then even if they said it was a decent level, it may not be a decent level because the tests are so funky.
Right. So there's the main protein that binds on the testosterone is called serum hormone binding globulin, or SHBG. So not to be too particular.
Yeah, no, it's good. SHBG, yeah. I could not get that out, save my life.
And so, for example, one of the things we run into the most with the women is that birth control pills can skyrocket their SHBG. So these women go onto birth control pills, these young women, and then all of a sudden they have no libido because none of the testosterone is getting out to their brain.
So if you're listening and you're hearing this, you know partially what's going on, because it's just crazy. Yep.
Yeah. And so the same thing is with the men, and also it depends on what threshold. Like the endocrinologists in general are very, very, they're trained that way. First of all, they don't know much about testosterone, which some of them will readily admit, but also they're very rigid. Like if you have every symptom in the book, but your number is 301 and 300 is the threshold, they will not treat you, And if they treat you, they'll get you to 400 for 3 months. And then if you don't feel better, they'll stop. So we're much more aggressive, about getting good levels for longer periods of time.
Right. So I think if you're listening to this, you need to understand that there's no objective reality number. There's certain guidelines, and you can correct me if you think that I'm saying this wrong, but there's certain like guidelines and like ranges you want people in, but very often we're treating for symptoms because that's really important. As long as if you have the symptoms and your testosterone is sky high, then nobody's going to treat you. But if you're trending towards the low level and you have classic symptoms, that's when you're going to get treated. But you need to have a lab that actually can do the job properly of testing and then following along with you on the trajectory, right? Because if you go to lab A and go to lab B, it's going to be totally different.
Right. So we always insist on doing the labs at our lab, first of all, because we do them well, but also then we have longitudinal numbers so we can compare apples to apples.
Right, exactly. So, okay, so now because I cut you off before, let's talk about, well, first of all, why don't we talk, how long does it usually take for you to see a response in the men?
Right. So I sort of make the men sign a verbal contract with me that if we're going to start testosterone, they're going to stick to it for a year. Otherwise, we're both wasting our time. And so the time frame that I give them is you have to give it 3 to 4 months to increase energy. It can take 6 months to notice a change in erections, and it can actually take 9 months to notice a change in libido. So unless we get good levels and we do it for close to a year, then we haven't really given it a try. And the libido is often the fastest one, the one that takes the longest time to kick in. But I do find that there's some patients, they come back after a month and like, oh my God, I feel 18 again. And I look at them and it's like, I am not making you 18 again. This is going to fall off. This is like going through puberty, all over again. And so the trajectory is sort of like there's a big bump, then they sort of come down and they go back obviously to better than they were before, but not at that like extreme fountain of youth level, which is not what we're for.
It's so funny because we have the same thing with women. We have some women, I wouldn't say most of them, but I would say maybe a third of them that come in there like immediately have a reaction and they're so happy. And then we like warn them, it's not going to stay like that. And then it kind of goes down and then slowly climbs up again. And I often say to the women, like, you don't want to feel totally different than you felt yesterday. I know when you have a fantasy, it's going to be great, but it isn't. Like, you want to slowly but gradually get back to a level that feels good. And we also, I would say 6 to 8 months with the women. That's what we experience. Like, we tell them they have to be there for a year because sometimes it takes that long. But we do see it sooner, especially now that we're using pellets, which I'm going to talk about. We'll go at the end, but that I feel like makes a very big difference for women. It somehow works better. That some delivery systems work better, but we'll talk about that in a minute. So let's talk about some of the reasons people are nervous about using testosterone, because I feel like that's a biggie, and I think a lot of the people that are watching are questioning that. So
for the men,
I know this is your favorite topic.
For the men, the two main issues that have been in the literature for different periods of time are, will it make me more likely to have prostate cancer, and will it make me more likely to have a cardiovascular event, basically a heart attack or a stroke? The prostate cancer issue has been left to bed, and I could go through the whole background, but the answer is no. And in fact, there is some data that says that testosterone may be protective for prostate cancer.
Did you guys all hear that? I just want to make sure everybody heard that, okay? Because that's the first thing I get all the time. So go.
Yeah. So, I mean, the genesis of that was that what's interesting is we know paradoxically that if men have metastatic prostate cancer, it has spread throughout their body, then we do need to remove all of their testosterone because it will slow the progression of the metastatic prostate cancer. So then people extrapolated, they said, well, if that's the case, then if we give regular men testosterone, then it's going to be like adding fuel to the fire. Basically, you're going to ignite prostate cancers. But we haven't found that at all. And so probably once you reach a certain level, not to be too technical, but you've saturated your receptors for testosterone on the prostate. So going from 300 to 609 to 1200 to 1500 will make no difference in terms of prostate cancer. At this point, just to really drive the point home, I often get a lot of patients that from Sloan Kettering or we work together with those patients. And there's something called the surveillance protocol where they're actually watching people with prostate cancer and not operating on them or doing radiation. And they're very comfortable with me having those patients with bona fide prostate cancer in place on testosterone. So it sort of puts that issue to bed.
That's real. I think for people listening, that's a really big deal, that and the quarterback. And for women, I think women are often very scared about breast cancer. And because, theoretically testosterone, I think, can convert into estrogen, but in the thousands of patients we've seen, maybe there's been one who's estrogen inclined. It's one of the reasons we keep a good eye on estrogen, but there seems to be no actual data that suggests that it really does convert in any real way. And if anything, again, there was some suggestion that it might be protective. So
right.
more and more. Go ahead.
With women on estrogen, I mean, even if it was converted into estrogen, the data that if that estrogen causes breast cancer is
Getting
very
weaker and weaker.
so.
Yeah, exactly. So for women, the typical side effects, and then you'll talk about the men. For women, the typical side effects, like if you don't have to worry about the big things, the typical side effects are hair growth, and I always say to people, you do not wake up with a beard or a mustache or a hairy chest. Like sometimes you'll have like an extra irritating hair, or if you had to shave, every 2 weeks, now you may have to shave every 10 days. That's kind of hair growth. Every once in a while, acne. Every once in a while, we see a clitoral enlargement when people want to be and are on kind of high levels. But if you stop it, it goes away. And those are the side effects that we see. And with the men, what do you see?
So we can see acne if they get high levels. The two main things that we're looking for in the men, which are true, is they can have an increase in the percentage of their blood that's made up of the red blood cells. So that's their hematocrit. And we keep a close eye on that, because if it gets too high, then we either go down on the dosage or they start donating blood, because that is true. If that number becomes too high and the blood becomes too thick, if we were not managing it, then they would have a higher chance, in theory, of having a heart attack or stroke. So we don't let it get to that point, obviously.
So the really important thing to take away for people here is if your husband or your partner is going on testosterone, or you're going on testosterone, you have to do it through a responsible place that keeps an eye on you. No matter who you are, it's not dangerous. It's perfectly safe, but you need to do it wisely, right? That seems like a fair thing.
Yeah, it has to be monitored. I'm always amazed. I mean, what I'm amazed in both directions, like how conservative people are. They will only go to a certain level, but it's weird because sometimes the people who put them on conservative level, amounts of testosterone don't even check the bloodstream. So, it's I don't really figure that one out. But so then the other thing that we look for is that, as you were talking about, testosterone gets converted into estrogen. And men have higher testosterone levels, so they get more conversion of testosterone into estrogen. And if that gets too high, some of the men can develop a little bit of breast tissue. So we keep an eye on that. Again, what the optimal level of estrogen, or when it's too high, is not even known. But we can knock it down very easily with something that inhibits the conversion of testosterone to estrogen. So those are our main side effects.
Right. And I know you said you see some good positive results, and you say it could take up to a year. Just spend another minute or two talking about the whole fat into muscle, because we see it less with women. We do see it a little bit with the women. I mean, I hate to say this because then I know we're going to get the phone ringing off the hook tomorrow. Oh my God, you can convert my fat into muscle. Like, I'll get on this testosterone. But with the men, I think you see it a lot, right?
We do. It's pretty dramatic. One of our patients sort of labeled it a virtuous loop, which is where, all of a sudden they have more energy, then they exercise more. If you have a low testosterone, you go to the gym, you're exhausted, you don't have a great workout, and you have a lot of like leg and muscle pain afterwards, and you don't notice any changes, and you just give it up. But then when they're on the testosterone, if we can get them to go to the gym the first few times, they notice that they have better workouts, they're not as exhausted, and they're putting on more muscle and taking off fat. We have a machine where we measure their their total weight, their percent body fat, their percent muscle, and it's really can be quite dramatic, actually.
So that's like an important thing. I often talk to women who for themselves are on testosterone, but also complaining about their husband, like their husband's a couch potato and he doesn't need to move, he doesn't want to exercise. And so this might be a good way for people to sort of approach it. Like, maybe your testosterone is low and maybe you should go see somebody about that. So, yeah.
The couch potato thing. If people are complaining of mid-afternoon fatigue, I mean, everyone, but significantly, that to me is almost like they have low testosterone until proven otherwise. It's fascinating. If a young person comes in and says, I literally have to take a nap in the middle of the day, especially if they have a normal sleeping schedule or not, a newborn baby or something like that, that is low testosterone almost always. It's fascinating.
So that's so interesting. For the women, we really find that for the women, the reason most of the women who come in, it's because their libido is just shot to hell and they can't seem to do anything about it. So what just for curiosity now, I'm just curious, what percentage would you say the men come in because they're tired or, low energy or depressed, and versus coming in because they have no libido?
Libido is a big one.
It is a big one.
Yeah, libido is a big one because there's always that expectation in society that men always want to have sex, and they're always kind of pushing their wives or partners to have sex. And so when you get it to the point, a couple really finds it very stressful when the wife or the partner, the female partner, if it's a heterosexual couple, has a higher libido than the man, and that just gets them going. So they come.
Yeah, that is a really hard one. Paul and I had a whole live on that. If you guys are interested in that, you can just check back. They're all saved on IGTV. So anyway, all right, now let's talk about how you give testosterone, because I think that's super interesting, and I think a lot of people don't know that. So why don't you kind of run through that? Because it's pretty much the same for the men and the women, just the quantities are tiny for the women. Yeah.
Right. So actually, until 2 months ago, we actually did not have an oral medication, which literally just got released in March. And now,
I cannot believe this. I did not know that. Right before COVID?
Yeah. So we've actually
oral, and it doesn't hit the liver?
No, it's fascinating. So
good. You go. You tell everybody and teach me.
So the problem with the testosterone, whenever you take a medication and if it's absorbed in your stomach, then it goes immediately, all that blood with whatever you took goes right to the liver, which is called, so the liver has to metabolize it, and the liver's getting a big spritz of that medication. Okay, so that's called the first pass effect. And if you take a pill of testosterone, that means your liver is getting a lot of testosterone, and that is not good. It actually creates a higher chance of getting liver cancer. So we haven't been giving oral medication in the United States for, I think, 60 years. But
60?
they did
60?
60, yeah. It has not been approved for years and years. I made that up a little bit, but it's since I know.
Close enough.
So, I was very excited today, told non sequitur. I'm an ice cream fanatic, and
yes, he is.
Yes, and especially coffee Haagen-Dazs ice cream and coffee Haagen-Dazs. Haagen-Dazs was created in 1960, and so there's all these big happy 60th birthday ice cream things, and I'm turning 60 this year with Haagen-Dazs, so I feel like they personally did a whole run just for me.
You know what? It's kind of a shame about COVID, because otherwise I know Grand Central Station would be giving out free Haagen-Dazs samples, and you would love that.
Okay, now you broke my heart.
I'm sorry. Maybe afterwards they'll do it. Anyway, so let's
go back to testosterone.
Yes, let's go back to testosterone. And let's talk about the stuff you've typically used until this point, because yeah.
So there is no testosterone flavored ice cream. But anyway, so now there's the pills are available, and we're just starting to use them, so I can't tell you what levels we're getting.
Do you think the women are going to be able to use the pills also, or no?
Well, the question is whether or not the insurance company will pay for them.
Well, I'm sure they won't. They don't pay for anything for the women.
Right, so they may be able to use them, yeah.
Except that the dosage might be too high. All right, go back to the other ones, and then we'll talk about the medical.
Yeah. So then there's there's topicals where you smear it on once a day. The men don't love that because they often don't get good levels. They don't get good absorption. It's sometimes not paid for by the insurance, but it is bioidentical, so we use that. There are other.
So I'm going to jump in here for a second.
Yeah.
So the men's stuff comes either. Okay, listen. There's nothing that is currently FDA approved for women, right? Any product that we give women, any testosterone anybody gives you, is off label. Like, we're giving it not approved by FDA because the FDA are just stubborn and slow. But hopefully they will be some soon. In Europe there is. So the men, when Dr. Werner says they smear it, they take like a huge pump of it or a huge tube of it or two, and they smear it all over the shoulder. And when we give women testosterone gel, it's a 10th. We start with the 7th or 10th of the male version, as much as we haven't put it on their thigh. Because sometimes you do get some hair growth there, and you don't want to have hair growth on your shoulder. So most people don't mind having a little bit more hair on their thigh, and they move it around. But the women are using the same exact gel as the guys, just a 10th of it. And then over time, we sometimes increase that. So it could be a 5th of it or a quarter of it, depending on what's going on. So I just wanted to jump in and say that.
Yeah, so we use the gel sometimes. There are patches which the men don't like. They don't get good levels. They're very irritating. There's one that goes in your nose 3 times a day, and then you can't blow your nose for an hour, so no one uses that. So the main ones that we use are now we're starting with the topicals, and then once a week, the man can give himself an injection in the fat. Usually we use the fat around the belly, which is where most of us have our fat, or they can give it into their thigh or their tush. So
now, are the ones that are injectable bioidentical? Because I feel like, okay, so just talk about that for 1 minute, because for a long time, I think you used it less. Now you're using it a little bit more. the women were using less injections. I don't think women love injections. I don't know if the men do, but talk about the bioidentical piece of it.
So the idea of bioidentical is that ideally you're trying to use exactly what your body makes, the exact same chemical. And they think one of the reasons why the women's study that came out 20 years ago that sort of put a dead stop to a lot of women using hormones were high levels of artificial steroids. So, and there was a small group of women that had a higher chance of breast cancer. It was a very idiosyncratic group. It was women who'd been gone through menopause, then went on and went very high levels of artificial hormones. But the idea is that it makes sense if you can, since people have been on testosterone, estrogen, whatever, to mimic exactly what they've been on all those years. So that's bioidentical. So the bioidentical options we have, which is why you started using them in the Women's Center, are the topicals and then the pellets. So those are my two favorite, the pellets are my favorite. And basically what the pellets are, they look like basically the size of a grain of rice. Yeah.
Tic Tac, right? Like a Tic Tac, yeah.
Yeah, Tic Tac's better than a rice. It's a little bigger than a grain of rice.
I don't know about your rice, but my rice is small.
I don't like rice, so I'd rather eat ice cream. And basically you put them underneath the skin, sort of in the fatty tissue, right, in someone's buttocks, in their tush. Not in the tush. Obviously, I've had patients who think that's where it's going, but it's going in the fat there. And then you put just a little dressing on it, and you put them in every 3 months. They dissolve on their own. You don't have to take them out or do anything like that. And then it gives you the good levels for 3 months.
So it's like, people should understand, it's like a procedure. Basically, they make this teeny little puncture in your tush, pop in the women's case, 1 to 2 pellets. In the men's case, like 18 pellets, right? Or 20 pellets.
Let's say, incision.
And then pop it in, and then basically, tape it up, because it's like having a teeny tiny wound in there. So
use a butterfly dressing, and then you don't have to put a stitch or anything like that. And they can, we just tell them not to swim for 48 hours.
The women love that because we love it. Like, back to what I was saying, the gel, it seems to take longer to get a good response from the gel. And I never am sure if it's because people forget to use it sometimes, if they're not using exactly the right quantity, whereas the pellet is in and out, and we are done, and we have to say goodbye. We'll see you again in 3 months.
Right. It's great for compliance also, because it's just done, and compliance levels with anyone is just hard.
So now just talk 1 more minute about the new oral stuff, because you really have. So is it a pill or is it a liquid?
So it is a pill, and what they did is they were very clever, is that it doesn't dissolve in the stomach. It goes through the stomach into the small intestine, and then it goes into, instead of the bloodstream, it goes into the lymphatics. So it doesn't go through the liver first.
So we could never use that with women, because it's a pill that's meant for men. We'd have to cut it into a 1/10 or a quarter.
No, because there's different dosages. The men have to take 4 pills a day.
Oh.
So we could give one, and there's 3 different dosages. So we could give 1 pill to the women. You couldn't cut it because that would ruin the mechanism.
Right. But if it's 4, you could do 1 every other day or something. That's fascinating. Okay.
Well, what you could do, it's 4, but then that's 4 of the medium-sized strength. So you might be able to give 1 of the lowest strength, and then you'd probably be giving 1/5 or 1/6 of the testosterone dosage.
So, all right. Well, if anybody who's listening decides they want to be a guinea pig to try this, come on in, because it sounds like we're about to try that. So, okay, we only really have 2 minutes left. I guess a woman asked me a question, which was, if you get on it, you have to be on it forever. I'm getting some hearts here. I think people like the idea of oral medication. Anyway, and I would say for the men, and you should respond to this, the men pretty much stay on it forever. The women, if you're postmenopausal, you don't have to stay on it forever, but often women want to stay on it forever because they feel so much better on it. And for the premenopausal women, it's almost usually not an issue. If you haven't had a baby, if you're thinking about having a baby, you're going to have to get off it at that point. And one of the things we do find is that sometimes if we get everything, we use it, it sort of jumpstarts you and you get everything else aligned. You can try getting off it slowly and see how you're doing. If you don't feel well, you come back on. And if you do, you stay off it. So I would say generally older women stay on it, younger women go on sometimes and then go off. And what do you do with the men?
So with the men, one of the concerns that the men have, that everyone has, is, okay, if I go on it and let's say I'm stranded on an island, there's a nuclear war, I can't get it, am I then never going to make my own? So it does pop back in. So they will be able to make it themselves. there's many men, if the thing about testosterone is it will temporarily shut down sperm production. You can't rely on it for contraception, but it's good enough that it makes most men not be able to have sperm. And so if the men still want to have kids, but they really need the testosterone, we'll usually have them bank the sperm just in case something bizarre happens. But we can then start pulling them off of it when they, want to conceive, and then we can put them back on it. So again, almost like with the women, they'll go back to the levels they were at when we take them off of it, but obviously they didn't feel great on those levels. So most of the time they just stay on it.
Okay. And then somebody else asked me about using other medications while they're on it. I mean, this woman asked specifically about Addy, and Addy, you can absolutely use it. Addy also works for low desire. But it works through your brain mechanism, which is a little different. So we often use it together, but at this point, there's really for the women at least, I don't think there's any contraindication of anything you can't use it with. What about you?
There's literally
I have that wrong?
No, in other words, it's a hormone. It's your normal hormone. So there's literally no medicine that is a contraindication for testosterone.
Right. So I think that's mind blowing for people. I think people think that that's crazy, but that is it. So, and then the last question I got, and we're done pretty much, unless something you want to add, was somebody asked about PCOS and can you give testosterone? And the truth is PCOS is so freaking complicated. And often they give you medication that kills your testosterone altogether. And that could be a real big problem. They're not sure that PCOS is caused by high testosterone. It could also be insulin. There's a billion other things that could be causing it. I think I'm trying to remember. There's inflammation. I mean, there's things that could be causing PCOS other than high testosterone, although they think of it as high testosterone. So if you have PCOS and you have low desire, you really kind of need to see a specialist and try to figure that piece out. Because my experience is doctors are like, who cares about the desire? Let's just, cut all your testosterone. And people have really bad reactions to that. Do you have anything you want to add to the PCOS question?
Not really. I mean, I do think it's its own animal, and the hallmark of one of the hallmarks of PCOS, and I really am not an expert, I will admit, was a high testosterone classically. And so what was always fascinating to me, which is is that the women would come in with these high testosterones, and they also, because of the high testosterones, they had a lot of hair, like a lot of body hair. They were heavier than the average, but their libidos were crazily high, and their husbands were unbelievably happy. So I always thought, women are very concerned about the way that they look, and their libidos are often much more important to their husbands than actually, some of the ways that they look.
Right. The piece of that always made me a little suspect also was that we don't really know what average testosterone is. So when the doctors are saying they have high testosterones, it's kind of an interesting question, like high for whom? Because anyway,
right.
Whatever.
But they sometimes will have symptoms of a high testosterone.
Exactly.
So they will have more bodily.
Exactly. Which may not be correlated. Okay. Is there anything about testosterone that we haven't talked about that you feel like we should, that I forgot or that you didn't mention? You want to give a little plug? Because I just feel like, what women, there's probably more women watching than men. So what would you say to the women who are watching about their husbands and testosterone or their partners?
I think if the men's libido are dropping, or they're finding that they're just are a couch potato, or they really are working hard at the gym and they're not getting any results, then in that case, let's just get their testosterone checked and let's see what happens. And the way I tell people is, if you have symptoms and if you have a low testosterone, in our experience, it's over 90% of the men will have a dramatic improvement in many of those symptoms over the course of the year. We're not talking about, I'm not sure, yes, no, but it's pretty dramatic for a lot of these men. I mean, they are really happy, and so are their partners.
Yeah, I mean, sometimes I feel a little jealous because I feel like the women, it's a little bit more subtle. I mean, I think the women see very effective changes, but it's not as dramatic. It really takes time and it's kind of slow, but all of a sudden women feel like, oh, I can have sex. They may not wake up running to find their partner, but they are like, I'm much more willing and happy to have sex, and the sex itself is much better and the orgasms are better. So we definitely do see a really good bump in it. So, all right, well, that's it, guys. Thanks for watching. Dr. Werner, thanks for making the time. I know you were dying to do nothing but come on live here.
It's my favorite.
I'm going to get you back at some point, but for right now, anyway, thanks everybody. Good night.
Good night, everyone. Thanks for joining. Bye.